Morning, everyone, and welcome to Coffee with the Commission. Today, we will be discussing the WMC Legislative Program with Micah Matthews, Deputy Executive and Legislative Director, and Stephanie Mason, Public Information Officer and Legislative Liaison. Before I turn the webinar over, I would like to take care of a few housekeeping items. We encourage everyone to ask questions throughout the presentation, so look for the chat icon on the Teams toolbar, and we will do our best to address your questions toward the end of the presentation. We are recording this webinar, and the on-demand version and the slide deck will be available on our website within the next few days. Please feel free to share these resources with your colleagues. And lastly, we want our learning events to be as interactive as possible. So feel free to use our social media platforms to share what you have learned and keep the conversation going. Now, with all of that out of the way, I will turn it over to Micah.
Good morning, everyone, and thank you for joining us on a Thursday of the legislative session. We are rapidly heading towards another cutoff on the 29th of March, so we're excited for that to happen as we whittle down the number of bills that we're tracking and trying to either get passed or offer amendments on or anything like that. So thank you again for joining us, and we're just going to get right to it. Maybe. So today we've got a couple of learning objectives for you. We want to help you understand how we approach the aspect of legislative programs with the Medical Commission, some overall things that we look at as far as what we track, and what determines our position on a bill if we take one, and then a state of the session from the Medical Commission's perspective. Stephanie?
Yeah, hi. I think most of you that are joining this know what the legislative process is, so I'm not going to spend that long describing how a bill becomes law, but just as like a quick overview, we've put this slide together. It's pretty rudimentary, but I'm going to go over it real quick. So when bills are introduced by a lawmaker, the first place they go is to a policy committee, unless they're strictly about funding. And in that policy committee, they receive a hearing and a vote out. Then the bill moves to a fiscal committee, then to rules, where it must be chosen by a member of those committees to be heard. And then after rules, the bill is placed on a floor calendar and receives a vote from the full House or the full Senate. The most important thing about this process is that none of these steps between the committees is guaranteed. So after a bill passes one chamber, then it's kind of got to start the process all over again in the opposite chamber. The most important policy committees for the Medical Commission and the place where most bills start for us are in the House Healthcare and Wellness Committee, which has 17 members. And this year it has a new chair, Representative Marcus Riccelli from the 3rd Legislative District. The second one is the Senate Health and Long-Term Care Committee. That has 10 members. And then this year, the legislature added a new categorization for us with the House Post-Secondary Education and Workforce Committee, which addresses the state compacts, and that has 15 members. And I think it's back to you, Micah.
Okay. So we're not going to belabor this point too much, but how a bill becomes a law, there's some helpful videos, as well as if you want more than a web page showing you the 8 steps of how a bill becomes a law, I would encourage you to watch the PBS video for a little bit of throwback action. And so we'll just move right along from that. And Stephanie, is this you?
I can talk to it if you want to. So this is just another kind of representative of the way that bills make it through session, but this one's based on cutoff. So as you can see, we've listed the cutoff calendar here, and cutoffs are really important because this is what the process of culling bills goes through. Not only is it hard for each bill to move in and out of committee, it has to do so by a certain number of dates. So as you'll see when we get to a later slide, we start out with a lot of bills in the beginning, and it's kind of a funnel that narrows as the session goes on. The next one, I believe you can see it on here, it's tiny for me, is March 29th. So we're coming up to yet another cutoff very soon. And I think the next slide is still me, Micah. So these are the 2022 numbers. It's also 21, 22. We work in bienniums, so everything is 2 years. We're on a 2-year fiscal cycle for the budget as well. So as you can see, there were quite a number of bills. It starts out with 2,835, and it gets all the way down to 303. Those numbers at the very bottom don't quite add up because there's vetoes, there's changes. So just because it passed the Senate and passed the House doesn't mean it passed both. Then it has to get to the Speaker and the Governor. So there are a few tiny hurdles there at the end. The Department of Health in those 2 years tracked approximately 100 bills and did analysis on all of those bills. And the WMC tracked 52. So the Department of Health has a much larger variety of legislation that they look at because they cover several issue areas, whereas the WMC is focused on the medical profession specifically. And the bill that was implemented last year was I believe the IMG bill, wasn't it, Micah?
Yeah, the clinical experience license bill. Yeah. House Bill 1129.
1129.
Yeah.
So, and we'll talk more about another IMG bill that's passing through the legislature this year. So, next slide, please.
This is the 2023.
Yes. So, we've heard that that there were more bills introduced in the 2023 session than in any other session. As we can see from 21, 22, that's not exactly true, but there is the idea that this year has been higher, more bills, and at a faster pace for a number of reasons, but it's still partially virtual as well as in person. So that's kind of contributed to the number of bills that we started out with versus the number of bills that are getting through the process. The Department of Health has 69 on their chart right now, which is less. There's been some interest in whether or not that's because the House Health had a new chair, so maybe they saw fewer bills. We haven't quite gotten to the end of that data and statistics yet, so we're not quite sure what the ultimate numbers will be. But so far, the WMC has tracked 49, and thankfully, and then not thankfully for some, we've gotten down to about 10, which we will show you on the very last slide. And then I think it's you, Micah.
Oh, wow.
Uh-oh. Back one.
Doesn't want to play. There we go.
Yeah.
Micah, if you go to the other end of your screen, it'll go back.
Gotcha. All right. So just for everyone's benefit, as staff of the WMC, we act according generally to the desires of the governor appointed commissioners. We're also part of the executive branch. So, what the governor's policies are, we generally do need to lend some support to those. It just depends on what the policy is and if the governor's office wishes to have support on that. That's relevant for this particular legislative session in light of the Dobbs decision and the big focus on what's called covered services, which is an umbrella term for things that are reproductive rights related and gender affirming care related. And so there's been quite a bit of movement in the legislative space for those items. So the first thing, aside from that defines what we do is our authorizing environment. So that's the Medical Practice Act, that's the Uniform Disciplinary Act, to some degree, the Open Public Meetings Act and the APA, or the Administrative Procedures Act. And then that's probably what I would call the broad upside down triangle, so the broad layer of the triangle. And then going down one level, you've got what the WMC does, which is its rules, its interpretive statements, bylaws, policies, guidelines, position statements, and procedures. And so generally, Stephanie and I are able to take those things and define a position on a bill. And it's generally because you're not seeing too much that's new under the sun that's being introduced as far as concepts. So if it conflicts with what our existing WMC stuff is, or if it's a change to the Practice Act, we'll generally have some form of opinion on it. And then We have the additional pieces of, how the medical commission actually functions, staff mandates in the form of union requirements, and then whatever budgetary impacts that happens. And then just to help out when we have bills introduced that don't fall under those buckets, we have a legislative subcommittee of commissioners who usually we utilize them with respect to, this is a really weird clinical proposal. We don't know enough about it. One of the classic ones was the ophthalmologist's proposals, where at reading through it, Stephanie and myself were having trouble pronouncing the words, let alone knowing the implication of the words. So it's really helpful to have a pro tem and an ophthalmologist who can define what all that is and really dig into what the concerns would be there. We also have, as I mentioned, clinical specialists that we can consult. And so when we get something that's really specialized or subspecialized, we do go to them to get clarity on what the impact would be. But generally, the legislature tends to refrain from introducing things that are super specialist related, thankfully, and they have over time realized that things that are standard of care probably should be left to the regulator and the profession. And so they do tend to kind of stay back on that generally. That's not always the case, and sometimes you see some things get introduced that we never thought we would actually have to deal with. So yeah, overall, our priority is always going to be patient safety and the operational ability of the healthcare system, and that's what's going to define what our positions are on bills if we take them, and so that's generally our guiding light there. And then these are the concepts that we track. Legislating the practice of medicine is always a concern. For reasons why we have concerns about that, look no further than states that have outlawed certain procedures and I'm not sure you can call them unintended consequences, but the consequences of outlawing certain procedures, and what we've seen in states like Oklahoma and Idaho, where you see practitioners leaving the state because of fear of life in prison or something for taking what would ordinarily be deemed as a life-saving measure. So we're seeing that, and we're thankful that our legislators don't really dig into that area, and just let the actual standard of care apply. Scope of practice bills, we've seen tons of those this year, and those are not going away. So we generally try and stay on the sidelines as much as possible for those, and let the profession actually deal with that. The times when we do weigh in is when it does appear that there's a pretty significant concern with respect to lack of training in doing something, and so that's generally what we'll look at. We do often have an attempt to make us participate in work groups or in some cases lead work groups. We're fine with those. That's to our mind, it's easier to come up with a policy position outside of the legislature and the bright spotlight of politics. And so having those debates and then bringing a complete and fully formulated policy back for consideration is always a preferable thing. We've seen new licensing categories get proposed in the last couple of sessions, and we are probably going to see another one proposed next session. So that's been seemingly pretty popular with the medical commission, or at least the folks who want to give these responsibilities to the medical commission. And telemedicine, I think we're not even close to done seeing what's going on with telemedicine. There was a Uniform Telemedicine Act that was introduced that didn't make cutoff this year, but I am assured that we're going to get some sort of consideration of that particular bill next year. So we'll see where that goes. And we're pretty in favor of putting a standardized policy of telemedicine into statute, and that way it will be more uniform and not existing in the insurance regulation, where it's not really logical to find the health practitioner standard of care when you're researching that sort of thing. So we answer a lot of questions about telemedicine and what's okay and what's not, based off of our policy, and that's really what kind of guides our position at this point. Everything else, we've seen a lot of media about most of these things. So when it comes to abortion laws, vaccine, we're always on the lookout for budget sweeps and account sweeps. And today at 12:30, we're expecting the Senate budget to get introduced. So we're really hoping that we're included in that. And so we'll be doing a lot of Control F searching throughout a very large document to make sure that we're included in there. Stephanie.
Okay, so I'll cover the first half of these bills. As you can see from our graphic, they're still alive, 10 of them all the way to the end. These weren't necessarily any bills that the WMC put forward, but they are ones where we've either been interested in what they would do to the medical profession, or we've been neutral, or in support. So, audio-only telemedicine. This bill's made it all the way to the speaker's desk, so it's highly likely that it will become law. It extends by 6 months the date by which an interactive remote appointment, so a video appointment between a patient and a provider, can substitute for an in-person appointment. That is only for the purposes of reimbursement. Excuse me. The informed consent bill is scheduled for executive session on March 29th, which is a cutoff day. That gives it about a 50-50 chance. It could be positive or negative for that being scheduled on that date. That bill has been amended 3 different times. That bill adds a new chapter to the UDA that requires a physician to provide a patient with a specific checklist of information during the first consultation for breast implant surgery. It also requires that they obtain written permission for the surgery at that first consultation. There's been some back and forth on that bill about trying to get it to match up with the FDA requirements, so that there isn't a patchwork of laws, but the Washington bill as it stands is more inclusive than the FDA requirements. The Death with Dignity bill has made it to Rules Committee in the second house, so it's very likely to pass. That bill expands the healthcare providers authorized to perform the duties of the Death with Dignity Act to include advanced registered nurse practitioners and physician assistants. It also reduces the required 15-day waiting period to 7 days for the drugs that are given for carrying out the act. The bill concerning female genital mutilation, FGM, has been voted out of committee in the second house and is likely to continue moving. The bill adds FGM as a chapter to the UDA, which is our disciplinary act, and its conduct requiring discipline when it's performed by a healthcare professional. Normally, we try to limit things that are added to the UDA, but this is one that the WMC felt was appropriate. It also includes FGM in the definition of child abuse or neglect that must be reported by a mandatory reporter. Doctors and PAs are in that category. And last but not least, the International Medical Graduate IMG Malpractice Bill is on the 3rd reading calendar right now. It's highly likely to pass. We've been in support.
It passed yesterday.
Oh, did it? Oh, nice.
Yeah, it passed out of the House yesterday.
I checked this morning and they hadn't updated, so hooray, it passed. That bill has not been amended since the beginning, and it removes the requirement that a physician supervising an IMG maintain malpractice insurance. The maintenance of malpractice insurance has made it difficult for IMGs to work with the limited license that we offer, so we're in support of that aspect of the bill changing. And how about you, Micah?
All right, and I'm just noticing that our little funny graphic might have made someone either laugh or cringe or be offended by the fact that we're looking at the Death with Dignity bill. So sorry if we offended anybody with that. But that was a little rough on. I chose that, so I'll take ownership of it now. So moving on to the Nurse Compact. As far as I know, this one is still moving. It's not dead yet. It was a little bit of a shocker because I believe we had a couple of versions of this, and historically it has not gone very far just due to some political pressures. Those same political pressures are existing, but we've had a change in the chair of the House Health Committee, who is no longer a nurse, and so that seems to have been a bit of a change there. For those of you who don't know, the Post-Secondary Education and Workforce Committee has been seeing all compacts, so they've been removed from consideration from the House side of the healthcare discussion. And they have very clearly stated that compacts are the policy of expediting licensure and workforce issues for this state. They've sent, I want to say, almost every single compact has gone through there without too much in the way of oppositional votes. So it's entirely likely that we will see the nursing compact become law. It will at least passed by the House and the Senate. I'm not sure if we will see a governor veto on this or not. That's a very politically dicey conversation at this point. Moving on to military spouses. So this one, there's been a lot of movement in this area, actually, both on the federal and the state level. So when this bill was introduced initially, there was a federal move to require effectively reciprocity for military members and spouses. And then on the federal level, it also required that if a military member or spouse was coming from a state with a compact that was a viable pathway to licensure in the next state, that they had to use that's fine with us. We've got the medical licensure compact. And for those of you who don't know, there's a PA compact that was introduced that was just passed by Utah as the first state. So we anticipate we will see something like that coming into Washington next year. So the military spouse bill by Representative Leavitt is one that effectively just determines that military spouses should be getting what I would call white glove treatment by the licensing groups. They have to process and consider the applications within 30 days of receipt of all the materials. They have to issue a temporary license that can last I believe no more than 180 days. So we already issue temporary licenses, so that's not too big of a deal. And then our only hang up on that was the definition of what a completed application is. We worked with the sponsor and were able to come to an agreement on that. I would anticipate that probably gets passed. It's been worked in a couple of previous sessions, and it's not going away. So we're certainly looking to see that go forward. Demographic information is one that doesn't directly apply to the medical commission, but we got engaged because we didn't want it to apply to us. For those of you who are not familiar, we've been collecting demographic information from licensees and publishing it in an anonymized aggregate format on our website every quarter since, I believe, 2011. And so the bill that came out for all of the rest of the professions would have limited what we asked, and would also have introduced some legal complications in our licensing law. So we asked to be exempted from that. One tag on to that is we've been raising the concern about data privacy with respect to collecting demographic and practice information. At this point, we want to work more with the sponsor to make sure that licensing data and demographic data and practice data is protected in a way that's more responsible and to some degree kind of conflicts with current state policy. So we will be working on the interim to make sure that that's more protected than it is now. 1340, health professionals. This is the one that relates to covered services that I talked about with reproductive care and gender affirming treatment. That is, and as well as 1469, that's the legal shield law. So the health professionals law basically prohibits the regulator from denying an application or taking an action about a covered service that was performed in another state that would be legal in Washington. So that's the key here. If it was legal and performed according to the standard of care, we will not take action on that, nor will we deny a license application over that. 1469 is covering everything else, which is when we're talking about things like subpoenas and extradition and all the other legal mechanisms with respect to what has been passed in other states. Such as what I call the headhunting laws, where anybody can file a lawsuit about aiding and abetting an abortion or any sort of regulatory action from another state. That's what the legal shield law is designed to protect licensees from those predatory practices in other states, so long as it was legal here. And the other thing that it does is we deal a lot with subpoenas, either issuing them or out-of-state subpoenas trying to be honored specifically through the compact. And there are provisions in that legal shield law that require folks to attest from out of state what the subpoena is about and if it relates to a covered service, and there are criminal and monetary penalties imposed if they misrepresent or lie about the purpose of the subpoena. So we're very happy with that because it doesn't put us in the enforcement seat when it comes to dealing with what's going on from an out-of-state actor. Whoa.
Thank you so much, and I hope all of you will join me in a virtual round of applause. Thank you so much for the wonderful presentation. Our attendees, please feel free to use the chat box to ask a question. And while you are taking a moment to formulate those questions, we do have a question that was submitted earlier, which is from Paul. It says, does a military spouse also include language to allow PA practice in Washington?
Both the federal law and that's a great question, Paul. It's almost like I know you. Sorry, that's a joke. Paul works with WAPA, and I also know him in my personal life, so he's a buddy of mine. Yeah, the federal law as well as the state law are agnostic with respect to the type of practitioner. It simply is looking more at if the state that the person is originating from has an equivalent type of license in Washington, then that's what they're trying to facilitate. So as far as I'm aware, every single jurisdiction in the U.S., and that I'm counting 70 jurisdictions, has a PA license or equivalent. It gets a little squishy around Georgia, where their anesthesiologist assistants are also physician assistants. But other than that, yeah, it would allow a PA to do that.
And you mentioned that WMC is tracking 49 bills. Can you go into a little bit more about what tracking a bill means?
Sure. So starting December 1st, the legislators can do something called pre-filing. And we get a daily list of bills that are introduced, but they're not, quote, read into the floor calendar. And I may kick it over to Stephanie to describe the floor calendar thing at a later bit. But we start seeing these bills and sort of like a preview. They've been probably working them with constituents, hopefully, and then in the interim, so probably from May to October, November, and then they pre-file them. And so on December 1st, you usually see like a big batch just dropped on the list for pre-filing. And so we look at those and we see if they seem to have an impact on the Medical Practice Act, the Uniform Disciplinary Act, the Medical Commission itself, our funds, where our funds are kept. And if they do, then we start tracking those bills. If they have some sort of a potential to impact the practice of medicine or the delivery of healthcare in the state by physicians or physician assistants, we do tend to take a minute to look at those to see what the general impact could be. So one example is informed consent. Doesn't necessarily impact the medical commission directly, but it requires that practitioners performing those breast augmentation procedures provide a very specific informed consent on top of the existing requirements for informed consent generally that exist in a law called, I believe it's 70.02 RCW. And so that's one where it's like, oh, there's not as much, but it's a requirement for practitioners. So, is it necessary, or is it just going to make it harder to work? The female genital mutilation bill, a little bit different because it adds it as a specific unprofessional conduct under the Uniform Disciplinary Act, and it adds a requirement that it becomes a mandatory reporting trigger. And so those are two things. One, it impacts the practice of medicine. Two, it requires specific action by the medical commission if we were to run across a violation of that. So those are the type of things that we track. As we go forward, we've got a list of bills for this session, and we kind of divide them up by House Health, Senate Health, and then Budget. And then as the bills don't make cutoff, they're dead, or mostly dead, as I like to say. and then we just kind of call the list as things get less and less. Any other questions?
It doesn't look like we have any, so I want to thank you again for presenting this valuable information. If you think of something you'd like to ask later, you can see their Micah and Stephanie's email on the screen, so please feel free to reach out. Thank you everyone for attending and participating. Have a wonderful week and remember to take care of yourselves.
Thank you, everyone.